My name is Dr. Greg Steiner. I am CEO of Steiner Bio. Today we're going to be talking about bone and how it determines implant success or failure. First, let's talk about what happens when you extract a tooth and you do not graft the site. Bone always heals inferior to normal, healthy, vital bone. When you extract a tooth, you never get complete volume replacement, you never get normal mineralization, and you never get normal vitality, and that is in a healthy young individual. However, when you start adding another series of negative factors on top of it, each of those negative factors make the bone that heals in that extraction site that's not treated inferior even more. You put in alcoholism and smoking and glucocorticoids, old age, diabetes. Every one of these factors add up to produce inferior healing in the extraction socket site. So the idea of doing extracting and not treating it is accepting inferior bone to support your implant. So you can see you have a choice. You can either put your implant in nice, healthy, vital bone that's on the left, or you can put your implant in poorly mineralized, low vitality bone that's on the right. On the left-hand side, that bone is treated to increase the health and vitality of the bone. On the right-hand side, it's a site that wasn't treated, and so you see you have poor mineralization and poor vitality. These type of structures determine the long-term success or failure of your implant. So when we talk about implant success or implant failure, the implant isn't successful and the implant doesn't fail because the implant doesn't do anything. The implant is an inert piece of metal. It's the same when you take it out of the box as to when it falls out of the patient's mouth. So the implant doesn't have much at all to do with its success or failure. Everything that's happening in success or failure is happening in the bone. If the bone is healthy, vital bone, it will integrate better. It will adapt to stresses and strains throughout the implant lifetime. If it is poorly mineralized and a low vitality, it will not be able to adapt to the stresses and strains that's placed upon that implant, and it will lead to implant failure. We're going to go over the instances where we can use technology to improve the health and the vitality of the bone and show that it provides us with excellent long-term success. Then we're going to go into the instances where we have poorly vital bone and it leads to implant failure. So let's get started. At Steiner Bio, our bone grafts are a combination drug alloplast. What that means is we actually have a drug inside our alloplast bone graft materials that stimulates bone growth. When we submitted this bone graft to the FDA, because it has a drug in it, it had to go through the drug division of the FDA, just like any other drug that you buy for medical purposes. And they required much more rigorous documentation so that we could actually make the claim that this drug actually does what we say it does. And so what we were required to do is we were required to do a human clinical study, and where we grafted 100 sites after extraction, waited 6 to 8 weeks to place the implants in, and these implants were placed in patients with no exclusions. Nothing. If you were a smoker, a diabetic, it didn't matter. This was a normal clinical practice where we placed these implants. And then once the implants were restored, each implant was followed for 3 years. And the results of the study was we had 100% integration and 100% implant survival after 3 years. Along with that human clinical study, we provided them with the histology, some of which you're going to see later, and that allowed us to get through the FDA with our drug, and we are the only bone graft that the FDA allows to state that we stimulate bone growth. Our drug has been determined to be safe and effective at stimulating bone growth. But another reason why we're here is clinical practice use. In this clinical study, we had great success rate, but what happens in the clinic? Well, over a period of 12 years of exclusive use of our graft material in a large group practice, they had a 99% plus implant success rate over a 12-year period. So this is not a scientific study, but they simply looked at how many implants were placed and how many implants were lost. They aren't looking at mean times that the implants are in the mouth. They're just looking at how many implants they are losing over this 12-year period of time. And they were found that it was very few, less than 1 a year, and they had a 99% plus implant success rate after 12 years. I'm going to show you now how you can achieve that in your own practice. What we're going to do now is we're going to show you how we can improve improve the health and the vitality of the bone that you're placing your implants in, and then we're going to talk about how that translates into a higher success rate over time. SL factor is the drug that we have in our bone grafts, and in front of you you're seeing a schematic of an osteoblast. You can see that there's all these growth factors with receptors in the cell membrane, and there's all these growth factors that float around outside the cell that send signals into the cell, and hopefully the signals get in that stimulates the cell to grow bone. However, our molecule is different. It's not a growth factor, it's a drug. It actually crosses the membrane, goes into the nucleus, and stimulates the DNA to produce RUNX2 and osteocalcin, and these master osteogenic molecules stimulate all the other growth factors like BMP2, WNTs. And so that's how our drug enters the cell and stimulates osteoblasts to produce greater mineralization and greater vitality. And we're going to show you histologic evidence of that in the upcoming slides. What we have here is histology of our graft material in an extraction socket. And what happens when you put our graft material in an extraction socket? The osteoblasts that are in the surrounding bone crawl into our bone graft material, and you can see the osteoblasts on this side. The orange material that the osteoblasts are crawling in is our alloplast. The vacuoles that you see scattered about, those are our SL factor or our drug, and you can see that osteoblasts are crawling around through this bone graft material and binding to these vacuoles and absorbing SL factor. From this point on, these osteoblasts are stimulated, and then they go about the process of rapid mineralization and rapid bone formation. And so this is what happens when you put our bone graft material in an extraction socket. This is one of my favorite slides. You can see in this slide all those cells are osteoblasts. You'll never see this produced by any other bone graft material because these osteoblasts have been stimulated by SL factor. They're multiplying rapidly. They're spreading rapidly. You can see there's immature bone formation in the periphery of this slide. And each one of those osteoblasts are in the process of finding an area in which they are going to begin the mineralization. And over time, what happens in this area will be completely mineralized, and many of those osteoblasts will then spread to surrounding areas to produce further mineralization in the surrounding tissue. This is histology from an extraction socket 6 weeks after grafting with socket graft. You can see that we have a good amount of mineralization. The pink material here is the mineralized tissue that's formed after 6 weeks. So it's approximately maybe 40% of the slide, which is actually within the normal range of percent of mineralized tissue in trabecular bone. Also, what's very important is you don't see any inflammation. There's no inflammation produced by our bone graft material. What we're doing with our bone graft material is we're stimulating the same process of mineralization that formed your skeleton in the first place. Your skeleton does not form with any inflammatory process, and that's the process that we're stimulating. And so when you stimulate these osteoblasts in a normal way, they produce mineralization and high vitality rapidly, but at its normal bone under normal bone formation conditions. As time passes, of course, these stimulated osteoblasts continue to produce mineralized tissue, and you can see there's a lot of blood vessels in these open vacuoles, so it's highly perfused, but you can see that at this point in time at 14 weeks in a bicuspid, it's about 80% mineralized tissue. The normal amount of mineralized tissue in trabecular bone is 35 to 45% mineralized tissue, and you can see we're about double that here. The arrows are pointing to a couple little graft particles that are left over from our socket graft, but you can see that bone is forming rapidly, and it's actually way past the percentage of mineralized tissue that's found in normal bone that is fully mature. So what happens if you give it enough time, in this case 6 months, because those osteoblasts are stimulated, they simply produce mineralized tissue until there's no more space. And then they actually go into the surrounding tissue. But here's a core sample after, from an extraction socket after 6 months with grafting with socket graft. And you can see it's solid mineral, but it has a lot of blood vessels, so it's very vital even though it's solid mineral. And as we discussed before, normal trabecular bone has between 35 and 45% mineralized tissue in it, and this is approaching 90% mineralized tissue. However, This is a solid block of mineralized tissue. That's not the best structure of carrying load. The key factor to our bone grafts, because it's normal bone and it's been stimulated, but it still has the potential to adapt and modify its stuff. When you load this structure, it converts into more of an ideal structure for carrying load. In the previous slide, you were looking at a solid piece of mineralized tissue that was a result of stimulating osteogenesis. However, that is not the most ideal structure for carrying load. Once you put an implant into that tissue, it remodels into what you see on this screen. What you see on this screen is a heterogeneous structure with the ability to self-remodel and self-repair. The trabeculi are aligned in a certain pattern for ideal carrying of load. You can see there's a significant number of blood vessels in the soft tissue that surround these trabeculi, and this tissue also has the ability to self-repair. Your skeleton is going through injuries on a continual basis. However, because your bones are normal, those injuries that form in the way of microcracks in your bone are repaired in a matter of about 2 weeks. Those repaired areas of microcracks are back to normal, essentially. However, if you do not have the ability to self-repair, those microcracks will accumulate and failure will result. So what you have here is tissue that can reorganize itself whenever there's a change in load in the implant throughout the person's life. Maybe they start to brux, maybe they lost a tooth and back, and the load on that implant changes. The tissue that the implant then must change and adapt to those changing loads. If it doesn't change and adapt, it will fail. And also, because bone is always subject to injury, this tissue that's healthy and vital will also be able to repair any microcracks that develop in the bone, and so those microcracks don't continue to develop and result in failure of your implant. Also, as you look at this tissue, the trabeculi are very organized. There's a significant amount of blood vessels, but also you see that there's absolutely no inflammation in the tissue. This is healthy, vital bone. So you've seen the histology that we provided to the FDA. You've seen how our molecule stimulates bone formation, and it produces much more bone rapidly than the normal healing process. And this is what allowed the FDA to allow us make the claim that we stimulate osteogenesis. Our graft materials, our socket graft, comes in 2 different dispensing systems, because some people like to pack their graft material and some people prefer to use a syringe. On the left-hand side, what you have is medical grade silicone trays, and you can see that the bone grafts are in these forms of these little petals in these different trays that you have. The tray on the left hand side is a 0.5 cc. The tray on the right hand side, the white tray, is a 1 cc tray of socket graft. These materials are kept in the freezer frozen, and what you do is when you have your tooth extracted and you've got the extraction socket cleaned out, then you go get the graft material from the freezer and you apply this material frozen. What you do is you take that pedal on the left hand side, your assistant picks it up, it sets it in the socket where you want it, you take your plugger on the flat end of that pedal and you press on it, and then when it contacts the bone, it actually melts the pedal. And so what you're doing is you're flowing the bone graft into the socket while it's essentially frozen. It melts and adapts to the socket beautifully, but it also allows you to pack it. And so when you're packing these things in, if you do get moisture, you can simply take some gauze, pack the gauze around it, dry the socket, and then continue to pack your petals until your socket's full, and it regenerates beautiful bone. On the right side, the same material comes in a syringe. The syringe is also kept in the freezer. You take it out of the freezer. It's designed to thaw in about 4 to 5 minutes. And so before you're ready to apply it, you need to take it out, let it thaw for a few minutes, and then when you got your tooth extracted, you simply inject it into the socket. And both of these graft materials are designed to be covered by Teflon membranes. You cannot use any human or animal materials with our bone grafts, because our bone grafts stimulate the normal process of bone formation, and any animal products such as collagen membranes will produce an inflammatory process that will interfere with the bone regeneration that our products are designed to produce. So let's start looking into the clinic and have some cases where we can actually begin to understand what's going on inside the tissue. Our company is very involved in the technology and the bone regenerative capacities of our bone grafts, and we want to know what they're doing inside the patient so that we can explain it to you so you can understand what you see in the clinic. Here we have a fractured tooth, and I'm going to extract this molar. Here the molar has been extracted. The site's been grafted with socket graft. This is 4 months later, and so now we're going to be placing our implant. What I want you to do is look closely at this bone, and you can see the interradicular bone that was between the two roots that was there at the time of the extraction. So the interradicular bone is there. The socket is filled up with new mineralized tissue. And what I want you to look at is what's not only the interradicular bone, but the new bone that's formed on top of the interradicular bone that goes to the crest, because we're going to take a core sample that goes through the crest into that interradicular bone. And so we're going to be taking a core sample of newly formed bone, and we're going to be taking a core sample of the bone that was there before the tooth was removed. This slide is the bone that grew on top of the old interradicular bone that was there when the tooth was extracted. So this is the bone that's at the crest. You can see that it's highly mineralized at this point in time. The bone is very nicely structured into trabeculi. There's no inflammation in the tissue, and this is beautiful bone for the placement of your implant. But the real interesting part of this histology is what's going on in the old bone that was there before the tooth was extracted. So this is the bone that was there before the tooth was extracted. However, you can see on the left side and the right side of this slide, you have bone that has lines in it, and that's what's called lamellar bone. That's old, mature bone that was there at the time of the extraction. And trabecular bone always has soft tissue between it, but you can see in this slide, in between the old bone on the right and left, there's new, immature, what's called woven bone that's grown between the old bone. So what's happened here is that you put your graft material in the extraction socket. The osteoblasts were stimulated. They converted the extraction socket into healthy, vital bone, but they weren't done because they're still stimulated. So when they get done with what they're doing in the socket, they leave the socket and they move into the surrounding tissue, and they continue to mineralize the surrounding tissue, increasing its health and vitality. So you not only are treating the bone that's in the socket, you're treating the bone that's around the socket, and that health and vitality spreads throughout the tissue. Now you can see that this is essentially 95% mineralized tissue. But the important thing with our graft material, because it is normal bone, once you load it, it converts into bone that's ideal for carrying load. Again, this is what it looks like after you put an implant in the area. That solid piece of mineralized structure converts into the ideal shape of bone that can carry your implant. The critical factors is that your implant needs to adapt to difference in forces throughout the life of the patient. Every patient and every implant is going to have changing loads depending on what's going on in that patient's mouth and the loads that the patients are placing upon that implant. And the bone that supports that implant has to adapt to those loads, or that implant's going to fail. Not only that, all bones in our body suffer minute injuries on a daily basis. They're called microfractures. And the bone must be able to repair those microfractures in order for the bone to not fail. So what happens in normal, healthy, vital bone, these microfractures are repaired within a couple weeks of their being incurred. However, when you don't have normal, healthy, vital bone, those microfractures are unable to be repaired. They accumulate and the bone fails. We're going to talk about that later. Okay, we looked at what happens in an extraction socket. We've looked at the type of bone that's produced and the spread of that vitality throughout the surrounding tissues. Let's get more clinical here, and let's start looking at integration to grafted areas of immediate implants. And a really well done study was done at USC by Becker and his group of researchers over there. What they did is they extracted teeth, they put in a titanium screw, grafted around the titanium screw, and then after that bone graft has matured, they cut out the bone and the titanium screw. And what they were interested in seeing is what type of graft material actually produced integration to the implant in the area of the bone graft, and they found that none of them did. They found that xenografts and allografts simply stopped once they got to the tip of the threads, and bone integration never occurred. That was a very interesting finding, because what it tells you is that if you're using some type of cadaver bone, it will fill the hole, but it won't support your implant at all. And that very is a big limitation on the areas in which you can put your immediate implants, because you can only rely upon bone support from the bone that the implant is in at the time of placement, and the area that's grafted is not providing any support for your implants. That's an interesting finding and an important finding, but the real interesting part of this study was that their statement that xenographic bone, demineralized freeze-dried bone allograft, appear to interfere with normal extraction socket healing. And the reason they made that statement is because they not only had clinicians involved in this study, but they had a world-renowned cell biologist by the name of Urist involved in this study. Urist knows bone better than anybody. He's the one that discovered bone morphogenic proteins. He is one of the best-known bone biologists there are, and they were able to get him in on this study, and I can guarantee you it was him that required them to put this statement in, because he knows what normal bone is. But in this case, where they were looking at the type of bone that was produced by cadaver bones, he knew that that was not normal bone, and that you should be cautioned about using that type of bone in your patients. And so we're going to talk more about the use of cadaver bone and his warning about interfering with the normal extraction socket healing. Now that we know that cadaver bones do not produce integration to the implant surface, let's look at graft materials that do. Here's an elderly lady in her 80s. You can see we have very poor mineralization after an extraction, and we want to put in an implant. However, once the flap is opened, granulation tissue is removed, you can see that we have no bone for implant placement. We have a huge defect in the buccal wall and a very large extraction socket that's much larger than the extraction socket of a normal tooth. So what we have for treating sockets that have defects in them, like a missing buccal wall, we have a product that's called Socket Graft Plus. Socket Graft Plus is the same thing as our socket graft, but it contains our beta-tricalcium phosphate granules. All granules do nothing but hold volume. And so we add the granules to our putty. The putty stimulates bone formation. The granules hold volume, like when you have a missing buccal wall, that allows you to regenerate that missing buccal wall with healthy vital bone. So we're going to use this graft material to place into that extraction socket and regenerate the bone. Okay, here we are with the site grafted. It was grafted with Socket Graft Plus. No membrane was used to cover this site. However, what we decided to do is simply place an implant in our graft material. You can see that this implant is placed in the site. You can see that the implant has no contact with the surrounding bone. It is simply floating in graft material. This is 3 months later. The implant is integrated. The buccal wall is regenerated. This is the 3-month post-op that we just showed you before clinically. This is radiographically. This is the time we placed the healing abutment. And you can see what happened here. This implant was simply floated in graft material. The surrounding bone grew into our graft material. The osteoblasts were stimulated. Those osteoblasts grew onto the surface of the implant, integrated to the implant, and now we have healthy vital bone supporting this implant. This implant is in the healthiest bone in this person's body because it is regenerated bone. No other bone graft can do this. No other bone graft in the world can produce this type of integration strictly through the bone graft material. This is that same implant after it's been restored. This is 1 year after restoration. You can see that you have excellent bone surrounding this implant. This lady is in her 80s. This is the healthiest bone in her body. This implant will guarantee you that it will last the rest of this person's life, and it was placed in nothing but graft material. And it shows you that our bone graft material can do things that no other bone graft can. So when you stimulate osteogenesis and you improve the health and vitality of the surrounding bone, that support for your implant results in a very high long-term success rate. Okay, let's get a little more practical from a clinical standpoint. Let's look at a site that's not the best site for an immediate implant. You have bone loss between 6 and 7. You've got debris out the apex of number 7. It's not the best site for an immediate implant. I was unable to get the amalgam out of the bone from the extraction socket, so I had to lay an extra flap in order to access all the amalgam debris. As you may well know by now, we name our products after what they do. This is a bone graft called Immediate Graft. It's designed to specifically graft around immediate implants, but it's also very effective for period lesions, endodontic lesions, etc. And so what we did in this particular case is we're going to use this graft material, and we're still going to go ahead with our immediate implant placement. So in this case, what I did is I put some immediate graft into the socket, drove the implant into that. Some of it came out the apex, and then I grafted over the coronal portion of the implant, which you can see graft material in place at this time. This is day of surgery. You can see the implant in place, and you can see the apical, I don't know, 1/5 of the implant is actually in normal bone, but you can see the majority of the implant is surrounded by bone graft material, and you can see around the coronal portion, you can see some of the graft material in that case also. This is 7 weeks after extraction and graft. You can see that there are a few granules left in the surrounding tissue, and we're going to place a healing abutment on this day. This is the same day as the previous photograph. You can see that the healing abutment is in place. This is 7 weeks after extraction and grafting. You can see that the bone is still a bit immature, but we have excellent adaptation to the surface of the implant. We have bone growing up to the collar of the implant and actually growing coronal to that. And so at 7 weeks, we've been able to regenerate this very large defect and produce excellent integration to the surface of this implant. This radiograph is after the implant has been restored, obviously. The bone is now much more mature, it's much more dense, and we can see that we still have excellent adaptation to the coronal portion of the implant. There's no doubt in my mind that this implant will last the life of this patient. So we've talked about grafting sockets, we've talked about grafting immediate implants, and when you look at the performance of the graft material, there's no other bone graft on the market or in the world for that matter that can come close to the stimulation of bone formation and the health and the vitality of the bone that's produced by our graft materials. Not only that, you've seen how our graft materials produce integration to the implant surface. No other bone graft has been able to show that that happens. Let's take a look at the sinus and see what our graft materials can do in the sinus. Well, about 15 years ago, I felt that drilling big, huge holes in people's skull and packing in cadaver bone grafts, and then waiting 6 months before you can put the implant in, and then waiting 6 months before you load them is a long, sort of abusive process, and I saw no reason why we couldn't improve on that surgical procedure and the outcome of that surgical procedure. So we developed a product called Sinus Graft. And we developed a surgery where what you do is you simply lay a flap for your implant placement. You find the very apical portion of the sinus, and you make about a 3 millimeter hole into the sinus just till you get to the membrane. You release the membrane, and then once the membrane is released, you put the tip of this syringe under the membrane, you inject, and the membrane is lifted hydraulically. At that point in time, you can put your implant in, so it's a graft implant placement at the same time. 3 months later, you bring the patient back for healing abutments. Because our graft material produces integration to the implant surface in the area of the graft material, you no longer have to delay your implant placement when you graft an area. So here is a case that we're going to do a sinus augmentation in, and of course we show you a challenging case so you can see how our bone grafts perform. On the left side of this screen you can see that we have a very large sinus with a mucus retention cyst in the posterior portion. I'm going to ignore that mucus retention cyst, just assuming that it's probably going to go away in time. I'm going to put an implant in the molar region, which is the area that has the least amount of bone. You can see that it's just a shell of bone at the crest. I'm going to put an implant in there, and then I'm going to put an implant in the anterior portion of this sinus, where maybe the implant will be in about 20% of the patient's bone. So the posterior implant will probably be in about 1% natural bone and 99% bone graft, and the anterior one will be about 20% in the patient's bone and 80% in the bone graft material. And then I'm going to put another implant forward of that into the patient's normal bone. You can see on the right side of the screen it has been grafted, but the problem I had is when I touched the side of this maxilla, the maxilla was about eggshell thickness, and as soon as I touched it, I tore the membrane that was underneath it, And then when I went to handle this membrane, it was like a wet tissue paper consistency, and I knew that there's no way I could handle this membrane. So what I decided to do is just simply scrape the membrane off the floor of the sinus, and I simply injected our graft material into the floor of the sinus, and at that point in time there was no membrane over the top of the graft material in the more cephalic portion of the sinus where the graft material was sitting with no membrane on top of it. And so I just proceeded to place the implants, and you can see on the right side I've got, I'm ready to put an implant in the patient's natural bone, and then posterior it, I've got the sinus grafted with the second implant going into a large portion of graft material, but a portion of the patient's own bone. The left side of the screen is the day of surgery. You can see that we've got the sinus filled with graft material. We've got 2 implants that have been placed in the graft material in the sinus, and the third implant is placed in the patient's own bone anterior to that. That's on the left side of the screen. On the right side of the screen, you can see that it's 3 months post-op, and we're going to be placing healing abutments at this point in time. You can see we have good bone contact at the crest of these implants. The implants are well integrated, and we have regenerated the sinus membrane over the top of our bone graft during the healing and integration phase of the implants. So you can see here again on the left hand side, that's the day of surgery. On the right hand side, this is 15 months after the implants have been restored. It appears that the mucus retention cyst is shrinking up a bit, but you can see we have excellent bone surrounding our implants. But the interesting part of this is that, remember, we talked about how when you put our graft material in, the osteoblasts migrate into the graft material. They're stimulated, and once they mineralize that area, they're not done, and so they start spreading into the surrounding areas. So you can see that the implant, the most anterior implant, is in the patient's own bone. But you can see that the bone around that implant is much more densely mineralized than the patient's natural bone to the right side of this slide. And the orange arrows are pointing to a migration of the osteoblasts and essentially a mineralization front as the osteoblasts are spreading into the surrounding tissue. And that gives you an example of the health and the vitality of this bone, and the fact that this bone will adapt, change, actually heal itself over time, so that these implants will likely function the life of the patient. These implants have been in place now 6 or 7 years. They're doing beautifully. The patient's on recall, and she's had no problems with these implants since they've been placed. There is no other bone graft material that has the characteristics and the potential to regenerate bone like this. In the beginning, we talked about doing extraction. What happens when you don't treat the extraction socket? You get inferior bone. This is another indication of that process. And so what you see here is, you can see that between the red arrows and the black arrows, you can see that this is an area that has less dense mineralization than the surrounding bone, both the bone between the roots of the teeth and apical to the area. You can see you have dense mineralization, but the area we're going to put our implant in, it is dark and not densely mineralized. And that tells you there that something, that bone is not of optimum health. But the real key to understanding what's going on in the bone is that the bone between the black arrows and the white arrows is cortical bone. Cortical bone never exists on the crest of the alveolus. If you ever see cortical bone on the crest of the alveolus, it tells you that the bone underneath it is very poor in structure and vitality, very poorly mineralized. The reason why cortical bone forms on the crest is to compensate for the very poor bone that's underneath it that's not providing any support. So the cortical bone forms to compensate for the poor bone underneath. And so when you see cortical bone like this, you know that you need to do something to improve the health and vitality of that bone that's underneath. So this is obviously an extraction site that wasn't grafted. As a result, we have very poor mineralization. I show this to the patient. I say, look, this bone underneath is going to be very poor bone. I need to treat that bone to improve the health and the vitality of that bone during the phase in which the integration is occurring, so that your implant will last your lifetime. And so what we did is we planned to graft this site at the time of implant placement. When you're trying to take Trephine samples of very poorly mineralized bone, it's very difficult to get those samples, but I was fortunate to be able to get a Trephine sample of that bone that we're placing our implant in, and we're going to take a little closer look at what's actually in that bone in the next slide. You can see here that the tissue that's in that bone is all fat cells. These are all fat cells, and you can see that you have an accumulation of inflammatory cells. I can assure you that you put your implant into this tissue and you're not going to get integration anywhere there where these fat cells are. You're not going to get integration to your implant, and your implant may or may not integrate, and it may or may not be successful long term. So what we're going to do is we're going to treat this tissue to increase the health and vitality of this tissue during the integration phase. We're going to use this product. It's called BioDensification. It's one of our putty bone grafts. It comes in a low volume of bone graft, because what we're going to do is we're going to drill a hole for our osteotomy. Before we put our implant in, we're going to fill it up with this graft material, and then we're going to drive our implant into that osteotomy. That's going to cause the bone graft material to be spread through that poorly mineralized bone. What's in our bone graft will stimulate the osteoblasts that are in the surrounding area, and it will regenerate the bone that should be in this area to provide lifelong support for the implant. Here's a case where we performed the osteotomy, filled it with biodensification, and now we're going to drive our implant into that site. So on the left, we have pre-op that I go over with the patient, explain to her how I'm going to treat this bone and the fact that I'm going to charge her for a bone graft. And on the right-hand side, you can see it's the healing abutment appointment 3 months after placement of the implant. So what we did is we grafted this osteotomy, then drove our implant in it, waited 3 months, and you can see that we have beautiful, healthy, vital bone in the area where there was originally all fat cells. And another interesting point, you can see that now that we regenerated the bone where the implant is in, the cortical plate has been remodeled. So when you revitalize the bone, underneath that cortical plate, the cortical plate is resorbed, remodeled into normal bone. We spent the first 2/3 of this presentation talking about how to create bone that is high in vitality, high in mineral content, but also has the ability to adapt to changes in load, that has the ability to self-repair in case there is injury. And that's what's necessary to provide the support for an implant to last the patient's lifetime. But just as important to that, we need to understand what causes implants to be lost. And in my instance, I learned a very good lesson, because I had a private practice at one point in time, but when I started my bone graft company, I'm essentially full-time running that bone graft company, but I still wanted to practice part-time, so I took a job working as a periodontist in a large group practice. This was a very high-quality group practice. They practiced excellent dentistry, and before me there was a periodontist there, was there for a couple of years. It was an excellent periodontist, very well trained, used all the latest techniques. He was trained at the University of San Francisco graduate periodontal program, and he was there for a few years before me, and so I took over from this gentleman. However, after a period of time, I started seeing a significant number of implant fails, and being in the bone business and being interested in bone biology, I was interested in finding out why we were having these failures, because these are failures that I hadn't seen before, because I'm using my materials exclusively, and I wanted to understand the process of how these implants were failing. And it turned out that as I examined and studied these failures, which were significant in number, there was one thing that was a common denominator. Every one of these implants were put in cadaver bone. So that prompted me to look closely at what these graft materials did in the patient and why I was seeing these failures. This is a lady that came to me. She lost this second molar. She was a young, healthy woman. She came to me for an implant, and so when I look at this, I'm looking at the anatomy. I'm studying what type of bone is being formed, and I'm going to be taking a core sample when I place my implant. There's a lot of anatomy here I could point out to you. We don't have time for that right now, but let's take a core sample and see what type of bone is produced by this material. So this is the core sample that came out of that young woman. You can see that there's an extensive amount of allograft particles scattered through this. The big one in the middle is identified, but you can see there's many more. And this is normal, what you get in the histology, almost all the histology on cadaver bone grafts. There's about 30% cadaver bone graft material left in the tissue. There is no resorption of this allograft material. I'm not going to go into it now, but it's never resorbed. It never changes throughout the life of the patient. These allograft particles are encased in what's called sclerotic bone. Sclerotic bone has been described as being a type of bone that is formed in response to inflammation. Sclerotic bone is very common in our knees and our hips. In fact, that's what orthopedic surgeons cut out when they put a new knee or a new hip in your body. They cut out the sclerotic bone, put a prosthesis in, and you're good to go. But inflammation in the joint or inflammation created anywhere in bone creates sclerotic bone. Sclerotic bone lacks the ability to adapt. It can't change. Once it's formed, it's set for life. It never adapts. And when you put an allograft or a xenograft into an extraction socket, it produces sclerotic bone that at that point in time is set. The grafts are never resorbed. The sclerotic bone is never changed. And so throughout the life of the patient, you do not have adaptation to changes in load. And also the material does not have the ability to self-repair. If any material that lacks the ability to repair itself will fail at some point in time. So we're going to look at some more of this sclerotic bone that's produced by these materials and talk about how it results in implant loss. Here's a site that was grafted with Bio-Oss 10 years prior. The situation is that the dentist looked at this bridge and felt that this bicuspid in front has significant periodontal disease and felt that the patient would be better off with extracting the bicuspid and putting in 2 implants. And he sent the patient to me, and I took one look at it and I said, there's no way I'm going to put an implant in this bone. I found out that it was Bio-Oss, and unfortunately the patient tried to get an implant placed into this material, but it failed. And so there's no way I'm going to try again, because I know this bone graft material is not really conducive for long-term support of a dental implant. And so I just told the patient that what you need to do is you need to try to save this bridge. So I did periodontal therapy on the bicuspid and got rid of the periodontal lesion. But when I did that, of course, I'm going to take a core sample of the Bio-Oss that's been sitting there for 10 years. And the Trephine sample on the left is what came out of that Bio-Oss. You can see there's simply chunks of cow bone in dense mineralized tissue, no blood vessels whatsoever. I can promise you that you put an implant in this material and it's not integrating, it's simply a screw in wood. Now on the right hand side, this is what a normal Trephine biopsy looks like. It's got nice vascular supply, solid bone, but you can see the difference between the two is the difference between failure on the left and success on the right. So here's the core sample that we took out of that Bio-Oss grafted site. You can see that there's multiple chunks of Bio-Oss left in it. It's basically nothing but chunks of Bio-Oss after 10 years surrounded by sclerotic bone. There's absolutely no blood vessels in this material. There's no osteoblasts anywhere in this material. This material is set in time. It's never changing because it lacks the cells that can change bone. And so if you screw your implant in it, you're simply putting a screw in wood. There's no integration involved. And what happens over time is that this material lacks the ability to self-repair. So if the load changes on this material, or any injury is caused by this material, and all bones suffer injury over time. Your skeleton is constantly suffering injury and repairing. The process is you develop microcracks into the bone. These microcracks are repaired over a 2-week period of time in normal bone, but if it's not normal bone like sclerotic bone, these microcracks are never repaired, and ultimately they accumulate to the point when it just collapses and the bone fails, or in your case, the implant falls out. So I am showing you sclerotic bone, telling you that sclerotic bone is the reason why your implants are falling out. But let's talk a little bit about how you can prove it to yourself that actually what's happening is the bone grafts are failing, and that's the reason why you're losing the implant. Well, as we know, in periimplantitis and periodontal disease, you have inflammation caused by bacteria in the gingiva. This inflammation causes resorption of the bone that either holds the tooth or the implant in, and that's the process, that's the disease process. It's resorption of bone ahead of the bacterial invasion, which, by the way, is a protective mechanism to avoid osteomyelitis, so the tooth or the implant is sacrificed in order for the patient not to develop osteomyelitis. But the situation is that when you remove the granulation tissue from a periodontal lesion or a peri-implant lesion, it's all soft granulation tissue and there's no bone in that material. Well, I'm talking about a different process where the bone graft material, be it allografts or xenografts, where the bone graft material isn't resorbed, it simply is broken up. It breaks up into little granules. And what happens when that occurs, these little granules are still oftentimes in the tissue. It depends on how long since the breakup has occurred. If it's been a short period of time, there'll be a lot of granules. If it's a long period of time since they've broken up, then there'll be few granules in the granulation tissue, because the amount of inflammation causes these granules of sclerotic bone to actually migrate out of the sulcus. But here we're looking at a case, and when I look at this, I'm looking at the bone around this implant, especially on the distal surface, and I can tell there's something wrong with it. That's definitely not normal bone. And when I look in the area of the lesion, I can see there's something in the soft tissue. There's specks of material in the soft tissue. But let's lay a flap and look at it. So I lay a flap to look at the tissue, to remove this implant, and when you look at the granulation tissue, you can look and see that just next to the retractor, you can see there's a whole mass of bone graft granules collected there. To the left of the implant, near the buccal ridge, you can see there's a couple pieces of bone graft granules there. And so when you have peri-implantitis or periodontal disease, you don't have any bone chips in the granulation tissue. However, when you have bone graft failure, you have plenty of bone graft chips in the granulation tissue, because the bone graft is simply breaking up into little granules. Different types of bone grafts fail in different ways, but most bone grafts fail that are either xenografts or allografts. They fail like breaking up into little chips. That turns into granulation tissue, and your implant is lost. And so what we have here is a way to make an absolute diagnosis that this is caused by bone graft failure rather than peri-implantitis or periodontal disease. So let's look at some cases. On the left-hand side, we have a beautiful implant, very nicely restored. Bone looks okay from here. All of a sudden, you go a few years later, on the right-hand side, the bone is blown out. And you go back into the history, and you see that this site was grafted with an allograft prior to implant placement, and this is bone graft failure. Bone failure due to placement of an implant into allograft. Here's another case. On the left-hand side, you can see there's an implant placed. You can look at the bone. You can see that it looks a bit different, not normal. However, on the right-hand side, you can see that the bone is blown out. You can see that actually in the granulation tissue, there's a significant number of bone graft granules floating around in the granulation tissue, and this is simply implant failure due to bone graft failure of Bio-Oss. This is an interesting case I just saw a few months ago. I placed this implant. You can see that it's a good size implant, proper positioning, beautifully restored, but the bone is blown out. What happened is I saw this patient, I placed the implant, he got lost, went to another practice, he came back to me 6 or 7 years later and looked like this. This gentleman's mouth was in excellent condition. His oral hygiene is excellent. He's beautifully restored. He goes in for regular cleanings. He has absolutely no disease in his mouth other than around this implant. And the reason is, this is bone graft failure due to allograft failure. Over time, the injuries to the bone accumulated multiple microfractures that are unable to be repaired because allografts produce sclerotic bone. Those microcracks or microfractures accumulate until the bone graft simply breaks up, and that's why this implant failed after between 6 and 7 years in function. Marginal bone loss is a big deal. Marginal bone loss is your first step to progression of the disease and implant loss. There was a very interesting study done a couple years ago, and what they were looking at, bone health or osteoporosis and marginal bone loss, and they wanted to determine if people with osteoporosis suffered marginal bone loss around their implants. And what they did is they placed implants, followed patients for 2 years. Some had osteoporosis, some did not have osteoporosis. And what they found is osteoporosis didn't have anything to do with marginal bone loss, but they also looked at a number of other factors in their study. It was very well done at a university, and they found one surprising thing. The only place where they found marginal bone loss is where implants were placed in cadaver bone. In that case, it was actually a xenograft, horse bone, doesn't matter, horse bone, allograft, it produces the same type of sclerotic bone. So this was a study that was produced. And then following that, a group at Tufts, they wanted to sort of question those findings. So what they did is they extracted teeth, grafted them with mineralized allografts, let that heal. Then they put implants in those grafted sites, and they put implants in sites that had not been grafted. And they simply, when the implants were placed, they covered them up, buried them, followed them for 3 to 4 months whenever they opened them up to put the healing abutment on, and then they looked at the marginal bone. And they were quite surprised to find that the implants placed in the mineralized allografts showed marginal bone loss, and the implants placed in sites not grafted with an allograft showed no marginal bone loss. And so here we have a prospective study in humans that document that when you want to put your implant in cadaver bone, you're going to get marginal bone loss. And that's the only thing that's been found to produce marginal bone loss. This is a very big deal because now we have scientific proof for why are you using that material and why are you putting implants in it. So this brings us back to the young lady that I showed you earlier who had lost a second molar and was grafted with a mineralized allograft. You can see this is the same slide that I showed you earlier. Well, I, at the time, was still willing to put implants into this material because I didn't really understand what was going on. So let's take a look at what happened when I place an implant into this site. Here's the site with the implant in place the day of surgery. It looks like the implant's pretty well placed. Let's take a look at it when I went to place the healing abutment. Here it is with the healing abutment placed 3 months later, and sure enough, look at the marginal bone loss that's been produced. I don't care what you do, I don't care how you place your implant or what type of implants you use. You put your implants in cadaver bone, you're going to start with marginal bone loss. And you can look into the gingiva, you can see all the bone graft particles that are floating out into the gingiva as they're broken up around this implant. We talk a lot about evidence-based dentistry, that we have to have scientific support for the things we do to our patients, and that's a very reasonable thing to have. However, there is almost no evidence-based dentistry when it comes to bone grafting. There are no studies of implants in sockets grafted with Bio-Oss. Bio-Oss is not cleared by the FDA to put implants in. The FDA knows that the only thing that holds implants in or supports implants for the long term is normal, healthy, vital bone. No xenograft produces normal, healthy, vital bone, so they have not cleared Bio-Oss for implant placement. There are no studies of implants in sockets grafted with allografts, if you can believe it. It's pretty amazing. We probably grafted millions of sockets with allografts over decades. There's been all this talk about how they work and, you know, what goes on in the bone and what mineralization process there are, which have all been proven wrong. And there's actually no studies of implants in sockets grafted with allografts for the long term. We simply don't have the studies. That's almost impossible to fathom in light of the fact that it's so easy to do these studies. You simply put an implant in, you put a crown on it, and you follow it for 3 years. That's the easiest possible study to do, but it's never been done with allografts. And I believe the reason it's not been published is that they don't like the results. However, the FDA does not permit implants placed in any xenograft because no xenograft produces normal bone. Allografts are transplants and not regulated by the FDA. It is the transplant doctor's responsibility to know how the transplant will perform. So the FDA backs out of transplants completely. They are not in the middle of any transplant material, and allografts are transplanted tissue. So the responsibility completely lies on the dentist that's doing the transplant to know how that transplanted material is going to operate in your patient. Unfortunately, any information we have on that is all false. We have no studies that say that it's effective, it's an effective treatment. And until we do get support for that, there is no scientific basis for grafting sockets with xenografts or allografts and placing implants in those sockets. Steiner Bio bone grafts are cleared by the FDA for implant placement, one of the few bone grafts on the market that is cleared by the FDA for implant placement. I've been doing bone grafts for a very long time. I actually used to use cadaver bone way back when until I just didn't like how it performed and decided I was going to develop my own line of bone grafts. And so what does a dentist do when he's recommending cadaver bone graft? Well, they sugarcoat it. And basically, when you tell a patient you're going to do a bone graft, oftentimes the first thing out of their mouth is what's in it. And what a dentist is going to tell their patient is similar to what I've got written here. It's cadaver bone, but don't worry, you can't catch anything from it. When I put it in your jaw, it stimulates your bone to grow new, healthy bone. And then your body breaks down the cadaver bone, takes it away, and leaves strong, healthy bone to support your implant. Not one thing in that statement is true. Nothing of it is true. And so what you're telling your patients is completely inaccurate. You're not lying to the patients because you believe what you're saying. Dentists believe what this statement says, but none of it's true because there's so little accurate information about what happens to the patient when the bone graft is put in there that they simply don't know that they're misleading the patient. But when the patient gets a cadaver bone graft that they don't want in the first place, and then they get their implant, and then that implant falls out, they're not at all happy about it. So let's wrap up this talk and discuss the fact that vitality is a very important factor in implant success or failure. What I'm trying to get across here is that bone vitality is the only thing that really matters when it comes to determining whether or not an implant is going to be successful long-term or not. High vitality, healthy, vital bone that can remodel and repair itself is going to support an implant for a lifetime. It is going to resist the diseases that surround it. However, low vitality, poor mineralization, poorly formed bone is going to be susceptible to any change in load. It's going to be unable to adapt and unable to respond to forces applied to it, unable to adapt and resist the pathogens that surround it. So let's look at a case and let's see what vitality can do for the support of your dental implant. In this case, you can see that we have a tremendously broken down first molar, severe caries, severe periodontal disease, endodontic disease surrounding it. Tooth number 17, severe caries, periodontal disease on the distal, endodontic disease, and you can see here is another tooth adjacent to this implant that is failing. However, when you look at the implant itself, it is perfect. When this implant was placed, those teeth were healthy. That implant was in a site with every possible pathogen you can consider. And as those adjacent molars broke down, all the load is being transferred onto this one implant. This implant, because it was placed in normal, healthy, vital bone grafted with our materials, was able to resist the disease and respond to the increase in load with bone up to the very collar of the implant, completely unaffected by the disease that surrounded it. So let's compare Steiner Bio bone grafts to cadaver bone grafts. Steiner Bio produces healthy, vital bone that is heterogeneous, adapts to changing load, and has the ability to self-repair. Cadaver bone graft produces homogeneous bone that is not able to adapt to changing load and is unable to self-repair. More implants are lost due to bone failure of cadaver bone than peri-implantitis. So, the end of the story is, how can you achieve a 99% success rate over time in your practice? We have had a number of customers of ours be with our company for many, many years, many of them over 10 years. And believe it or not, they report the same finding. They report the numbers of failures over time is extremely small and almost imperceptible, to the point where they feel they have a 99% success rate. And you can achieve that same thing when you're using a graft material that produces healthy, vital bone that can adapt to changes and resist disease. And this is our line of product that we offer you, and we hope that you will contact us, talk to us about our bone grafts. We are different from all other bone graft companies. If you've got a question about a bone graft, whether it's ours or another one, call us up. You're going to get somebody knowledgeable on the other end of the line, somebody that's been involved in dentistry for many, many years, and somebody that can answer your questions and give you an honest answer on what's the best bone graft for you.